Hi, thank you for joining our webinar. Today, we're going to be focusing on strategies and trends for cutting RX spending for employers. I'm Reagan Corliss, and I am a strategy marketing manager here at MedSavvy. So now I'm going to introduce you to Dr. Sean Karbowitz, our featured speaker. Sean Karbowitz is the founder and general manager of MedSavvy. Prior to MedSavvy, Sean held clinical and operational pharmacy leadership positions at Regions Blue Cross Blue Shield, in which he developed and oversaw products and evidence-based programs to promote safe, cost-effective use of medications for health plans and pharmacy benefit managers.
Great, thanks Reagan. So what we'd like to do now is offer you a view from inside our corner of the prescription drug coverage industry. So we'll share with you our perspective on how the market's been moving, where it was, where it's going, and how we see the medication market landscape changing. So what I'd like to do is talk about how we ended up in some of the circumstances we did, what we see unfolding in the future, and learn from some of those previous experiences so we could better prepare ourselves for those future trends. The key takeaway of this presentation that I'd like you to keep in mind and think about is it's no longer possible to set it and forget it. There was a commercial several years ago, you might have heard it, where the sales pitch was set it and forget it. And we can't think that just because we put a program in place or that it's going to work indefinitely. And we'll talk a little bit about why that is, what the changes are that are coming in the market, and what are the things that you might have to do to think proactively about your pharmacy benefits. So let's go ahead and jump into the agenda. So what we'd like to do first is talk about safety and some lessons learned, particularly around Oxycodone, the brand name Oxycontin, and the opioid crisis that our country is experiencing. And we're really dealing with the fallout and the aftermath right now. Now, we might not think about how prescription benefit coverage could have impacted the safe use of Oxycontin, but I'll share an anecdote with you. We often do think about costs, and there's a lot of conversation right now currently around prescription cost management, but we can't take our eye off the ball of safety and prescription benefit value. So let's go ahead and dive right into to safety. Now, we often think about prescription benefits as, well, a benefit, as an enhancement, and we need to continue to do that. The challenge with drug coverage at times is because we focused on cost, some of the barriers that have been put into place to manage cost have created some hassles for consumers. So what we're going to do is we're going to talk a little bit about some of the management techniques from a safety lens and really focus on the issue of cost. My call to action to you is to really get involved, roll up your sleeves. Again, this isn't set it and forget it, but we'll give you some questions to ask, recommend that you listen to your employees to see how the benefits unfolding, and really help you get prescription value. Okay, so let's talk about OxyContin. So in this slide, what you see is the amount of OxyContin that was consumed in America, and the US is the blue line, versus Europe over time. Now the timeline on this graph is pretty small, so I'll walk you through it. What we see in the late 90s is a spike that starts to occur of how much oxycodone, was dispensed in our country. The reasons for this were a couple-fold. One is these products were heavily promoted. The manufacturers of some of the branded products promoted these products very, very heavily to physicians. There were well-intentioned clinicians who had a problem, and this medication, these types of medications, were seen as a solution to the problem that they were dealing with. The problem really boils down to, from my perspective, that physicians prescribed a medication that did not have adequate evidence of benefit for the condition it was being treated. And this is really the crux of the situation that I'd like to focus on, and I'd like to get you to think about a little bit as you're thinking about prescription benefits. So the question is, what if a prescription benefit covers a drug that really lacks adequate evidence that it's going to improve health, and what are the ramifications of that? So one impact of the prescription opioid crisis that we have and that we're currently experiencing is an increase in opioid overdoses currently, and we've certainly seen this in the news. And what we see in this chart is a mortality graph. There is an increase in opioid-related deaths that have occurred starting about 10 years after the increase in prescriptions of these medications. So we see a lag after medications have been used inappropriately at great quantities. The fallout starts to occur. So certainly there's a lot in the press around opioid overdoses. We're starting to see this bleed over into heroin overdoses. So you'll see a spike in the orange line, which represents heroin overdoses as well. Significant dramatic impact of a medication that was overused and it has gone wrong. In addition to deaths, perhaps some under-recognized impacts of the opioid crisis. About half of the unemployed men in America are on opioids for some reason or another. So there are manufacturing facilities, there are employers who are dealing with record low unemployment, and they're unable to hire workers because those workers are dependent on or addicted to opioids. Opioid-related deaths have now surpassed motor vehicle accidents as a cause of death in the United States. So an extraordinarily dramatic impact. So how does this potentially relate to employer coverage? Well, I want to share a story that I was personally involved in back in the mid-2000s of an employer that recognized the potential harm that could have come from opioids. And there was a manufacturer who was involved in the fitness industry, and one of those senior executives in that company experienced a tragic personal loss due to opioid medications. And they recognized that as a fitness, as a healthcare related company, that they could do better, that they could take a stronger stance. And they worked closely with their pharmacy benefit manager at the time. I was involved in the program, and we worked with them to really make sure that opioids were only covered for the sickest patients who could benefit from those therapies. And we were very vigilant about making sure that people didn't get prescribed excessive quantities of opioids. So the balance that we experienced and that we had to strike was, on one hand, there was concern about the safety of the use of these medications for the employer or for the employees, and so there were some restrictions that were put in place to ensure that the medications were used safely. On the other hand, there was a view of a hassle or some friction because of the way that those programs were put into place. There were restrictions on access. And the expectation among many employers that we were dealing with at the time was, the drug is FDA approved, it's prescribed by a physician, it should be covered, so cover the drug. Why would you implement restrictions or hassles or burdens on these medications? But I would like to think, in retrospect, after seeing how the opioid crisis has unfolded over the past couple of years, that we took steps to relieve and to prevent some harm from these medications. So there's good news that has out of this opioid crisis. So first, there were changes in the laws around the use of opioid medications that have led to a significant decrease. In 2014, 2015, there was a change in the way that certain medications were dispensed by pharmacies, and that has led to a dramatic decrease in the overall amount of opioids that were dispensed. There's also just a lot more public awareness around the scope of this problem. The next good news is that there are tools and resources available. The National Safety Council, as an example, has resources for employers that mirror a lot of the programs and activities that we used back 10, 15 years ago to help people raise awareness about the problem. So I believe that employers have a key opportunity here to help their employees by, one, implementing benefit designs that can help reduce unsafe medication use, but also by communicating with their employees, showing that they care, raising awareness to this problem, which has ultimately become a public health issue. And then, so finally, my perspective, the lesson learned is that it's everyone's responsibility to ensure safe and effective medication use, and that employers do, in fact, play a significant role. So what are the lessons learned? What can you do? The moral of the story is that just because a medication is FDA approved does not mean it will be used safely. So ask if your prescription benefit covers only or prefers the safest, most effective medications. I will say, and perhaps this is the topic for another webinar, that there is increasing focus on the quality or the effectiveness of medications that are coming to the market. We've seen, for example, an increase in the conversation around the potential lowering of the threshold that the FDA is requiring for a medication to come to market. And so there's increasing discussion around that. The reality is that the FDA is subject to political pressures. They're subject to some pressure to ensure that people have access to therapies. We've heard about, you might have heard about the right to try legislation, where the FDA is allowing more unproven therapies to come to market. So the lesson really here is make sure that your prescription benefit is attuned to this and is looking at not just cost, but the safety and effectiveness of medications. So speaking of costs, let's go ahead and talk about the elephant in the room, which is medication-related costs. So how have we been doing over the past couple of years related to medication cost control? I've been in managed care for about 20 years, maybe a little over 20 years. And as a pharmacist, working hard to make sure that people have access to affordable drug coverage, and that we can take steps to lower the cost of prescription drugs. So let's look at the track record. This graph represents prices from 2008 to projected into 2022. How have we been doing? Well, I think there's room for improvement. Medication prices certainly continue to be in the news. They continue to rise and have impact on consumers. So let's look at some of the drivers of medication cost increases. And I'm going to talk about the drivers that maybe are a little bit different than you might think. And we often hear about innovation, increased use of medications, and those are all true and drivers, and there's lots of on that topic. But what I want to talk about for us is the effect of some of our benefits and benefit designs. A particular topic that was discussed quite a bit in 2019 were medication rebates. And you may have heard the conversation that HHS, the United States Health and Human Services, and CMS, Centers for Medicaid Medicare Services, had considered taking steps to eliminate or reduce how rebates, prescription drug rebates, were used in payments for benefits. And long story short, cut to the chase, rebates are here to stay. During that evaluation period, it was determined that the government really would potentially cause more disruption by eliminating rebates, and might not actually help consumers if they implemented programs to mandate the elimination of rebates. We also have heard that PBMs and health plans are attempting to use those rebates to benefit, more specifically benefit the consumer by having those rebates available at the point of sale. Let's talk about what rebates are, how they work, and I'll unpack this slide for you a little bit. So first of all, let's talk about how a rebate might work. So on the left side of the slide, we see a drug company or a manufacturer. And when a new medication is approved by the FDA, oftentimes a manufacturer will approach a pharmacy benefit manager, and they will come to an agreement or have a discussion around how a medication is going to be covered. So oftentimes a manufacturer will pay a PBM a fee in order to have that drug listed on that preferred medication covered list, called a formulary. So the fee will be in the form of a rebate oftentimes. And this makes sense in a way, because the PBM is attempting to use their purchasing power, the pool of healthcare purchasers that they've assembled, to negotiate a lower price from the manufacturer for the members. So the PBM will, again, use their purchasing power, negotiate a lower price from the manufacturer, and the way they do that often is in terms of a rebate or a discount, and that is also perhaps considered a fee that the manufacturer pays the PBM in order to have their medication covered and coverable under that PBM benefit. So those dollars in the form of a rebate may be passed through back to the health plan. In this case, the health plan might be an insurer, it might be an employer-sponsored benefit plan, but the health plan can use those rebates, again, to offset some of the costs of coverage. So the health plan's purchasing power, the amount of rebate they can get, is often driven by the size of that plan, the size of that purchasing pool, and that can drive deeper discounts and greater rebates. In this example, we have a patient at the center who is paying both the health plan for their coverage in the case of an insured population, an insured patient, or perhaps the employer is paying the health plan for the premiums in this case. Now the patient, when the patient goes to the pharmacy, they're going to pay the pharmacy for their co-payment for the prescription drug. The dilemma occurs when the rebate that flows back to the health plan might not impact the patient's drug cost at the time of the prescription. So in other words, the rebate might not be applied to the price and reflect the price that the patient actually pays. In some cases, the patient might receive the benefit of that rebated drug because in order for the drug to be preferred on that formulary, a rebate would be necessary, and then that means that that drug is available at a preferred copayment. So the patient might pay a lower cost in the form of a preferred copayment in that circumstance. But that's not always the case. If the benefit perhaps is a 20% coinsurance, the patient's paying 20% of the unrebated price of that drug. And so the dilemma that occurs is that patients are paying a copayment based on the full amount allowed rather than the rebated price in many circumstances. So what are the downsides of rebates? Well, rebates could be perceived as a tax on the sick or a penalty on the sick, and that's certainly something I've heard. Since rebates that are then used to perhaps lower the premiums are funded by the prescriptions of those rebated medications that are in many cases paid for by the person who is using that medicine. So in some cases, the people who are using the benefit are subsidizing, if you will, are perceived as subsidizing the overall prescription benefit. The other concern that I want to raise your attention to is that rebates might be guaranteed. They might be as part of a prescription benefit. They might be guaranteed in a benefit contract, and then that can then reliably offset prescription benefit costs. So what that means is very much like your tax return, right? So if you have the government withhold a certain amount of your money, you'll come to count on your tax return after you file your taxes on April 15th. And I know some families rely on that tax return, and some some employers would rely on, or health plans would rely on those rebates in order to fund and have an impact on the benefit costs. The downside is that the absolute dollars that you're paying in order to get that rebate aren't often tracked clearly. So what we see are rising prescription drug prices over time. They drift up because those are being used to fund rebates on the back end. What's a specific example of how this could potentially impact a patient? So we have two examples listed here for two different types of medications. I'll walk through an example. Forgive me if the example is not, these are fictitious examples. They're not, there's definitely different benefit designs that can unfold and handle these circumstances, but let's look at some of these examples. In one case, on the left, we have rheumatoid arthritis, and we see Humira and Orencia. Both are A-graded drugs to treat rheumatoid arthritis, meaning they have very good evidence that they improve symptoms for those conditions. In this case, Orencia is priced slightly lower than Humira based on the amount allowed based on prescription claims data that we've seen. So if you see that for example, in this example, if Humira is a preferred product and a consumer has to pay a 20% coinsurance, the view of the consumer is that they are being required to pay a higher price drug, or being required to pay for a higher price drug. Now, on the back end, the rebate might lower the cost overall to the plan, but from the consumer's view, they're paying 20% of that total cost, that total amount allowed. In the case of hepatitis, the difference could be even greater. Now, these are very, very expensive drugs, and I'll acknowledge that many times people hit their out-of-pocket maximum, and so the point becomes moot. But this will hold true for lower cost medications as well. If a drug has a high price, in the case of Harvoni, and it's preferred and it's required that the person uses Harvoni because that's the preferred drug under the formulary, and a person's paying a 20% coinsurance, they're going to pay a lot more out of pocket than if they were to use the alternative, Mavorette, and pay 20% of that cost. So you could see that if a person's paying a percentage of the overall cost, the higher cost medication can certainly impact how much that patient's paying out of pocket, and it can contribute to rising costs over time. So the lesson that we're seeing and what we're observing in continued rises of prices over time is that short-term saving strategies might not lead to sustained cost control. So I would recommend that benefit plans promote medications of the lowest net cost and of good clinical value, and attempting to do that with as little reliance on rebates as possible. By encouraging true price competition in the marketplace and encouraging consumers to select drugs that are lower price, that can drive prices down at the manufacturer level and can also increase the need for high quality medications. So again, the point is to pick a benefit plan that selectively utilizes rebates, perhaps on those medications where the price of the drug compared to its competitors is comparable, and not when the price of the drug is significantly elevated and with a dramatically elevated rebate, because that can have a potential adverse impact on consumers. So let's look at another concept that seems to be unfolding. I would say that there's two medication markets currently that exist. And as you think about prescription benefits, they're going to need to support both of these types of medication marketplaces. On one hand, there are medications that you are probably familiar with, and some of those examples I listed in the previous slide, where there are relatively few options. They're high-cost options, and those medications are priced on a value description. I'll go into more detail around that, what that means. But suffice it to say that for some conditions where there are few treatment options, how those medications are priced is different from other medications or other conditions where there are many choices. In the second scenario, where there are many choices, a free market type of approach can help drive down prices. And I'll walk you through an example of that, and we'll see data that shows the greater the number of options available to a consumer, and if the consumer is able to select those options, prices can actually go down. And it also raises the question of quality. So let's go back to that first example or that first market type of specialty and value pricing, and we'll walk through an example of ICER, the Institute for Clinical and Economic Review. They are a group that reviews medications and assigns and describes a value of those medications. So we'll play a short video and walk you through ICER. We might have to email. This video doesn't seem to be working, so we'll skip on, and I will do my best to summarize the video. But suffice it to say that the way this works is there are a group of scientists, non-biased scientists, who are not affiliated with the pharmaceutical manufacturer necessarily, or with health plans. They're an independent entity. And those scientists will take input from the manufacturer, from employer groups, from health plans, from patients, and from providers, and try to understand what is the value that a medication will provide to the patient and to society overall. And taking this approach can help inform a fair price for the medication. The alternative is that the price is maybe not ethically imposed, and we've certainly seen some examples in the news over the past 10 years or so where a manufacturer might come up with an unfair price, an overly burdensome price on medications. So what ICER or other groups like ICER is attempting to do is to take input from a variety of stakeholders and come up with a fair price based on the drug's value. And they do this for medications that are usually rare diseases with limited choices, limited treatment choices. Oftentimes, cancer medications can fall into this value price bucket, depending on how well that medication works. And then precision medication therapies or precision medicine therapies like genetic treatments, genetic gene therapies as an example. And we'll go into the example on the next slide of what those gene therapies might look like. So two examples of extraordinarily expensive medications: Luxturna for an inherited retinal disease that can cause blindness, and the treatment is around $400,000 per eye. Zolgensma, which is used for spinal muscular atrophy, a genetic condition in small babies, $2 million per treatment. Now, these are gene therapies. These are extraordinarily sophisticated, extraordinarily complex, using the most cutting-edge science in order to treat these diseases. So they are very, very expensive, and there's a very small number of people who can benefit from these drugs, and the price reflects that. So what ICER does is they take into consideration the effectiveness of the drug, how many people are affected by the drug, and try to come up with a price that can help be determined as fair. So let's walk through a quick example of a medication where ICER has had a significant impact on the price. So one example is Praluent, which is a medication for cholesterol. And when this medication came to market, it was priced around $14,000. A treatment After ICER reviewed the medication, they thought the price should be somewhere around $4,500 to $8,000. And after that evaluation came out, the manufacturer did work with pharmacy benefit managers and health plans and lowered the price in the form of a rebate, in large part influenced, I believe, by ICER's analysis. So what we see are now cholesterol, high cholesterol isn't uncommon, but at the time this was for a limited indication for a very relatively small number of people. And so as ICER has gone through their processes, we've seen that it does impact the price that a manufacturer will charge. Now, these are very, very high cost medications, and as such, employers are going to grapple with how these are covered. So one way that so as we look to how employers are anticipating coverage for these medications, one is this concept of a government-sponsored benefit program for specialty medications. So according to a survey of employer groups, a majority of employer groups would be interested in having some sort of a national program that covers these very rare, very expensive medications at a national level. Now, there is also a non-government sponsored program that has come to market in response to these high costs. It's called the Embark Benefit Protection. It was developed by Express Scripts and Cigna. And this is a commercially available product that spreads the risk out among employers. And the goal there is that it has predictability in terms of cost for the employer and a low or no out-of-pocket expense for those patients that are affected. So the key point here is that these are rare diseases, value pricing might be needed, and that because the cost is so great, it might have to be spread over a large population in order to make it affordable. Certainly, medications of $400,000 a treatment or $2 million a treatment are not something many employers can just absorb. So when this is necessary in your population, some of these additional programs that are coming down the pike might need to be considered. So let's look at the second medication market type, which is really when there are multiple medication options available. And in this, I call it it's just a competitive free market. And what we see in this slide here is that as the number of products increases, the cost goes down over time. And so this specific example is looking at generic medications and how many generic manufacturers are putting a drug product in the market. So we see 1, 2 to 10 or more. And when you get to about 3 generic manufacturers, the price really starts to be significantly lower than the innovator product. Now what we see this sometimes with branded medications, where as more branded medications come to market, the price might go down, but oftentimes the price goes up. And that's in large part, I believe, because benefits are not encouraging competition. What we see when it comes to generic medications is the price does come down, and we'll talk a little bit about why we see the price come down in generics and why we're not seeing it in brands, and that we can make changes to the benefit structure and through increased transparency and shopping to mimic the results we're seeing here with generic medications. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing we need is transparency. Consumers need to know what are the choices that are available, what are the prices of those choices, and what's the quality of those choices. If consumers don't have access through transparency, if they don't know what things cost and how well they work, we're not going to have a functional marketplace. In the case of generics, generics are brought to the patient often by the pharmacy. So the pharmacist is letting the patient know there's a lower cost alternative. It's a very easy switch. The next characteristic is it's a reasonable choice. So in the case of generics, generics are a very reasonable choice because they're viewed by the FDA as therapeutically interchangeable. The pharmacist can switch them, and so it's a reasonable clinical choice. In the medication, in other medication conditions, or when we think about brand to brand choices, many times there are multiple choices that are reasonable. We just need a way to compare them. And then the next, which I sort of alluded to, is the ability to make a change readily. So in the case of a pharmacist switching from a brand to generic, that's very easy to make. The pharmacist can do that on their own without the intervention of a physician and make that change on behalf of a consumer. So having the ability to make a medication change can also help to lower the cost. And then finally, there has to be some benefit to the stakeholders who are making that decision. In the case of a patient, patients often benefit from generics because they're paying a lower coinsurance. We can replicate that same type of benefit from a brand to generic switch between brands of different prices if the patient has a co-payment differential where they're encouraged to take advantage of a lower cost product, for example. So if the patient has skin in the game, they'll likely get the benefit of that increased marketplace competition. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing we need is transparency. Consumers need to know what are the choices that are available, what are the prices of those choices, and what's the quality of those choices. If consumers don't have access through transparency, if they don't know what things cost and how well they work, we're not going to have a functional marketplace. In the case of generics, generics are brought to the patient often by the pharmacy. So the pharmacist is letting the patient know there's a lower cost alternative. It's a very easy switch. The next characteristic is it's a reasonable choice. So in the case of generics, generics are a very reasonable choice because they're viewed by the FDA as therapeutically interchangeable. The pharmacist can switch them, and so it's a reasonable clinical choice. In the medication, in other medication conditions, or when we think about brand-to-brand choices, many times there are multiple choices that are reasonable. We just need a way to compare them. And then the next, which I sort of alluded to, is the ability to make a change readily. So in the case of a pharmacist switching from a brand to generic, that's very easy to make. The pharmacist can do that on their own without the intervention of a physician and make that change on behalf of a consumer. So having the ability to make a medication change can also help to lower the cost. And then finally, there has to be some benefit to the stakeholders who are making that decision. In the case of a patient, patients often benefit from generics because they're paying a lower coinsurance. We can replicate that same type of benefit from a brand to generic switch between brands of different prices if the patient has a co-payment differential where they're encouraged to take advantage of a lower cost product, for example. So if the patient has skin in the game, they'll likely get the benefit of that increased marketplace competition. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing, so what are some lessons learned here? There are often lower cost options available, and we would encourage you to look for a benefit plan that supports that healthy competition and can take advantage of the fact when there's multiple options available, that can lower the cost of prescription drugs over time. All right, so what are some of the benefit designs that have popped up or are evolving in response to prescription medication costs? So just as a reminder, how we've been doing to control drug costs, we haven't done a great job over the past 10 years or so. So let's take a look at what employers have done in response to that. As we look out on the landscape, we are seeing increasingly complex prescription benefit plans. 45% of prescription benefit plans in 2019 have 4 or more tiers. When I started in managed care 20 years ago, we probably had oftentimes we had 2 tiers. You had a brand tier and a generic tier. And now we're seeing preferred brand, preferred generic, preferred non-preferred brand, non-preferred generic, specialty preferred, specialty non-preferred, and a host of other tiers. And those are increasingly complex. How are members going to keep track of those? So we certainly see a trend in the benefit designs for increasingly complex benefits. So we have a survey question for you, and we would like to know, what is your general feeling about the current state of the healthcare industry? And so we have 3 responses we'd like you to answer, considering: are quality and costs worsening? Are you very pessimistic? Are they about the same? Or do you see that quality and costs are improving? I just showed you a slide of what we think we see in terms of costs overall, but we'd like your opinion on this. So take a moment and go ahead and click your response. And then when you're done, we will share those results with you. All right. So how did we do? Oh, we have a pretty pessimistic group of participants, that quality and costs are worsening. So let's see. So we're not the first to ask this question. What we see here is a survey of 200 executives in the healthcare industry, and they too, the majority, have their opinion is that quality and costs are worsening or about the same, but very few believe that quality and costs are improving. So there's definitely some room for improvement here that we can take a look at. So we have another question for you. So let's look at where the industry is going, and what we see is similarly that there is an increasing focus on cost and quality in the industry. So there's a trend towards a movement towards value-based care. There's a clear recognition that just focusing on cost is not going to be sufficient. We need to focus on quality as well, because that can impact overall costs over time. So let's look at some of the components of value-based care. What is it, and how does it relate to medication? So value-based care is a term that we can unpack a little bit. The characteristics of value-based care really includes payment for quality, not just volume of services, but a payment with a focus on improving quality over time. Improving outcomes, and it's not just volume of care, as I mentioned. The components that you might see in a value-based care arrangement perhaps are bundled payments. So rather than paying for various individual services or metrics, what we're paying for is a bundled service, like a knee replacement, or like the total overall care of a patient. We're seeing centers of excellence, which means for certain procedures, whether it's perhaps a transplantation, orthopedic surgery, cardiovascular surgery, there are centers of excellence that employers or health plans are focusing on and working with in order to drive volume of care and drive value and lower prices. We're also seeing this reflected in tiered copayments. So for those plan participants who utilize those centers of excellence, they have lower out-of-pocket costs. And if the employee or the plan participant chooses not to use the center of excellence, they might have higher costs overall. We're also seeing primary care getting involved in contracting to deliver value for the payers. And why this is important for medications is it may or may not include medications in that value-based care. So let's look at some of the components of value-based care. What is it, and how does it relate to medication? So value-based care is a term that we can unpack a little bit. The characteristics of value-based care really includes payment for quality, not just volume of services, but a payment with a focus on improving quality over time. Improving outcomes, and it's not just volume of care, as I mentioned. The components that you might see in a value-based care arrangement perhaps are bundled. So let's walk through a specific example from the Cleveland Clinic and their medical home care delivery team that they've developed in order to impact the quality of care. So the way this works is there's a patient with a particular condition, in this case inflammatory bowel disease, very serious condition, and rather than paying for individual episodes of care, if you will, the idea was, how can we assemble a team around that patient and address that whole person and really get them better? So the team comes together, discusses that patient, and works to improve their care over time. This on a small scale, so value-based care on a small scale, can work. And CMS, the Center for Medicare and Medicaid Services, which sets the tone of how medical care is delivered, has been experimenting with this. They started MIPS, the Merit-Based Incentive Payment System, And the goal here was to drive value-based care. And so let's look at the results on a large scale, not just one clinic, but across the country. And what we see are the results are mixed. In 2017, value-based care actually increased costs by about $115 million, although they initially reported a savings of $167. Last year, they reported out the results of 2018, where they had about a 1% savings using value-based care methodology. So the bottom line is that we have some mixed results around value-based care. This on a small scale, so value-based care on a small scale, can work. And CMS, the Center for Medicare and Medicaid Services, which sets the tone of how medical care is delivered, has been experimenting with this. They started MIPS, the Merit-Based Incentive Payment System, and the goal here was to drive value-based care. And so let's look at the results on a large scale, not just one clinic, but across the country. And what we see are the results are mixed. In 2017, value-based care actually increased costs by about $115 million, although they initially reported a savings of $167. Last year, they reported out the results of 2018, where they had about a 1% savings using value-based care methodology. So the bottom line is that we have some mixed results around value-based care. And our value-based payment model can lower costs, but scaling it is going to be challenging. So we have to pay attention on this over time. The next trend that we're seeing in the industry is much tighter integration of pharmacy and medical benefits. And the reason that we see this is that an integration can lower overall costs. We've all heard the analogy of squeezing the balloon. If you squeeze one side of the balloon, in this case, the prescription benefit, costs could balloon out on the other side of the equation. And similarly, if we tighten medical management and shift costs over to the prescription drug side, we might see costs balloon over there. But an integrated approach can lower costs over time, and that's why we're seeing this vertical integration in the industry. We also see a trend in uptake of prior authorization. So based on a survey of employers, what you see in this chart is the percentage of employers indicating that they are taking these steps, and the lighter blue indicates 2020. Most employers are planning on implementing more prior authorization, more utilization management to address specialty costs. The problem with this approach is that it's frustrating to medical professionals. So while it's a step that's being taken, and it's a step that has been implemented in the past, we're not sure it's a sustainable, it's ultimately leading to sustained downward cost. It's certainly something that's necessary in the short term, however. I'll briefly talk about some of the disruptive technologies and approaches that we are experiencing in the industry, and we'll wrap up shortly. So the first is an increasing access to data. What we're seeing is an individual right of consumer access to their own data. And CMS has launched an initiative for Medicare patients to have access to their data through the Blue Button initiative. And what this is going to enable is more easily have patients' data transferred to themselves so they could use it in their own medical care, and they can transfer it between physician and care. We're also seeing an increased effort for price transparency. By having access to data, consumers can make better decisions. And what we see here is President Trump and Seema Verma from HHS working together to drive increase in price transparency. And there's certainly a lot of initiatives on the federal level to make prices more transparent and available to consumers so they can become better shoppers. And we're seeing that, with interoperability and real-time benefit check. We're seeing CMS consider requiring health plans to make prescription drug prices available in electronic prescribing systems for providers so that they could select the lowest price drug. And then finally, we're seeing big data get into the game. Cloud servers like Google and Amazon, AWS, Microsoft, etc., are working with health systems, and the one that was in the news recently was Ascension and Google working together And the moral of the story here, or the thing to pay attention to here, is that the data needs to be used appropriately. So one of the things you'll want to be paying attention to is, where's your data going, and is it going to be guarded appropriately, and is it going to be used for appropriate purposes? We are also seeing a minefield of information for consumers. And so this is a growing concern as well, potentially, and a potential disruptor. Social media and other technologies are making information more readily available to consumers. The question is, how high quality is that data for consumers? It's blurring the lines between what people are seeing between experts and information that's shared between peers. There's certainly an increase and continued spending by pharma to promote their medication products. And we're seeing some potential concerns around drug deliveries from out of the country in response to high drug prices. So something to watch out for are medications being shipped in that perhaps are not of the highest quality for consumers, as consumers are pivoting to in order to manage high drug prices that they're experiencing. Finally, the last point I'll make before I wrap up our disruptions is we're starting to see pharmacists take a more active role in delivering care. And I've listed a few examples here where pharmacists are becoming more and more active managing prescription drugs for consumers. So in Oregon, for example, pharmacists are now able to prescribe birth control. Pharmacists in Oregon are expanding their capability over what medications they can manage. In Idaho, for example, pharmacists and pharmacy technicians are prescribing naloxone. And in California, pharmacists are prescribing HIV medication. So this is enabling and starting to change how we're thinking about where medications get started, and then once they are started, who's managing the medication. So we're going to want to start to think about how we can incorporate pharmacists to help manage and lower costs for consumers overall. So in summary, what can we do to really learn from our previous lessons, and again, watch where the market's going, and see if we can pick the best prescription benefit for employees. So one, our recommendation, pick a benefit that encourages medications of good clinical value, cost and quality, and see if we can generate savings without relying too heavily on rebates, because they can be potentially problematic. Also, look for a benefit plan that does support healthy competition. Competition can improve quality and lower costs, so encourage your employees to be better healthcare shoppers whenever possible. When it comes to data, support health plans that encourage data transparency and data interoperability. That can enable solutions that help consumers make better decisions and can lower the cost of care. Watch for more changes here in the future. There's going to be a lot more coming. This is just a brief introduction. And then finally, stay involved. Support those services that encourage your employees to stay active in managing their health. There are innovative services on the way that can potentially disrupt. That can be potentially disruptive. And I do have one request. If there are other topics you'd like to hear about, or if you have feedback on this video, we're open to hearing it. So please do share those ideas so we can help meet your needs.
Yes, we have that in the form as well, to request your feedback on additional ideas you'd like to hear about. Thank you again for attending. And stay on our emailing list, because we have an agenda throughout 2020 of useful and helpful webinars in which you will also be able to get SHRM and HRCI credits for. Thanks again. Bye.